Welcome to the On Target podcast. On this podcast, we discuss the ins and outs of radiation therapy. We talk with doctors and patients about what to expect during radiation treatment. Each episode will be a unique perspective of different aspects of radiation oncology and radiation treatment. For more information or to learn more about radiation treatment, please visit our website, rtanswers.org.
Hi, everyone. Welcome to this episode of the On Target podcast. My name is Niema Razavian, and I'm a resident physician at Wake Forest University School of Medicine. In this episode, we will be providing a general overview of different types of radiation therapies. To do that, we have Dr. Sameer Keole from Mayo Clinic, Arizona, where he is a professor, and he is also the incoming president of the American Society of Radiation Oncology. So thanks for being here today, Dr. Keole.
Thank you for having me.
Okay, so I think the first question we really should address is, what is radiation and how does it work?
Radiation, broadly speaking, is what we call on the electromagnetic spectrum. And its mechanism is to damage DNA, but it's very targeted. So we're very good at focusing the radiation on the bad stuff and avoiding the good stuff.
And what kind of diseases can we use radiation for?
Generally speaking, we use radiation against cancer, but sometimes people say we should really be using the term radiation medicine because we can use it against diseases that are not cancer. And this is a growing indication, certainly around the globe, that's coming into the United States. So some commonly used indications are something called trigeminal neuralgia, which can cause horrific pain to patients, and we can really help those patients. A growing indication in this country and across the globe is osteoarthritis. Another example is paragangliomas, which is a kind of a rare tumor that affects people in the head and neck region. So there's a lot of benign, or we call non-oncologic indications for radiation as well.
What type of doctor prescribes radiation?
Great question. So to become a radiation oncologist requires a lot of education and training. Radiation oncologists are physicians, so they have a four-year medical degree, so they'll either have the letters MD or DO behind their name. And after that, they have 5 years minimum of postgraduate training, generally a year of general medicine, most commonly internal medicine, and then 4 years of radiation oncology specific training. Your typical radiation oncologist, by the time they finish training, has had 10,000 hours of post-medical school training.
And are radiation oncologists the same as radiologists?
No, they are different. Historically, they were the same, and so there's still confusion. We started as a branch of radiology, but starting probably in the late 50s and throughout the 60s, we split off into our own residency. And today, there's only training programs that do radiation oncology. And so we have our historical roots are in the field of radiology, but we really are focused heavily on oncology, although again, we do treat some patients who do not have cancer.
And you mentioned previously that radiation oncologists use radiation to treat different types of diseases. Does every radiation oncologist treat everything, or do some specialize?
Great question. And so you have a little bit of both. And so there's a lot of radiation oncologists who will see a wide spectrum of cancers and other diseases, and then you might go to larger places and they'll have radiation oncologists who just focus on maybe just one or two disease sites. And so it really depends on where you are. I think it's important to emphasize that nearly all radiation oncologists, and probably everyone that anybody listening to this podcast will see, is board certified to treat really any disease.
Right. And as part of their training, like you said, those 10,000 hours, they'll learn to treat both cancer and non-cancer indications.
Exactly.
And are there other people that work with radiation oncologists to deliver radiation therapy?
Great question. Yes. So radiation oncology in many ways is the ultimate team sport. We are in the middle of a lot of things, but this certainly takes a village. And so on a daily basis, we're working with multiple different people in a dosimetrist helps us do the planning. A physicist does a lot of the work to make sure the machines undergo quality assurance. Radiation therapists are actually on the machine working with the patients every day to deliver the directive. I see my nurse every day, multiple times a day, to take care of patients, and amazing front desk staff to get patients checked in, and medical assistants to room the patients, and also to help with other vital signs and take weight. So yeah, it's many different people in the department to take care of that single patient.
And if a patient ends up needing radiation, how do they get set up to see a radiation oncologist?
There's a few ways. Sometimes they are referred by another doctor in the process of cancer care, and sometimes the patients will find us on their own, and they can self-refer. And so it's a variety of ways. Radiation oncologists are very good at working with other cancer doctors, cancer providers, surgeons, medical oncologists. And so it's, again, the team approach is not just in the department, but it's outside the department as well, working with other doctors.
And when is radiation typically given? Can radiation be given by itself? Is it given before or after surgery?
So radiation can be given in really three broad buckets. We sometimes give it before surgery. A lot of times we give it just by itself, and we use it as what we call definitively for the cure. And sometimes we use it after surgery, and that's called postoperative radiation therapy. So it really depends on the clinical situation for that particular patient.
So, can radiation be used to cure cancer?
Absolutely. So radiation oncology, radiation therapy can be used to cure cancer and has a very successful track record of curing cancer either by itself or sometimes in conjunction with chemotherapy. One of the common things we do is we use it to avoid surgical removal of an organ. That can be really appealing to a lot of patients, and if the clinical situation is appropriate.
What are some examples of cancers where radiation can essentially be used to preserve that organ?
Yeah, one of the classic examples, there's two I'd like to highlight. They're very interesting. Anal canal cancer is cancer exactly it sounds like. It's of the anal canal. And it used to be that patients would get surgical removal of the anal canal, which meant they had to get a colostomy. They could no longer use the anus for defecation, and it would come out on the side in a pouch. And this was a curative procedure, but obviously was not appealing to all patients. There was an interesting study done at Wayne State University where they tried giving just 10 days of radiation with a slightly higher dose per day. And they took the patients to surgery and found that all the cancers were gone in all the patients. So that then led to subsequent studies showing we no longer had to do a colostomy to cure anal canal cancer. We could give them radiation combined with chemotherapy and allowed them to keep their bowel system entirely intact. And so basically organ preservation. Another great example, also done ironically out of Southeast Michigan, was to use it for a voice box cancer called a laryngeal cancer. So it used to be that if somebody got a voice box cancer, we'd remove the entire voice box. It was, again, curative, but patients couldn't speak after that. And they tried using radiation in lieu of it and found it was equivalent. And so typically it's very rare now that, except in the most advanced cancers, that we would have to remove the voice box for a laryngeal cancer. So radiation has really improved the quality of life for not just patients with GI cancers and head and neck cancers, but a variety of cancers.
And speaking of quality of life, we talked a little bit about using radiation to cure cancer. The radiation can also be used to improve symptoms from cancer. Is that correct?
Yeah, absolutely. Sometimes patients have advanced cancers. And so while we'd like to cure everybody, there's some patients who are going to come into our department and get what we call palliative radiation therapy. So what does that mean? That means these patients come in with significant pain. Perhaps their cancer has spread to a bone and it's causing debilitating pain, preventing them from enjoying their life. What we can do is give high doses of radiation to a very small volume and really alleviate the pain in a very short amount of time, allowing them to be active and enjoy.
Now let's talk about the different types of radiation. Can you tell us how radiation is given and a couple different types of radiation?
There's a few different ways to give radiation therapy. Broadly speaking, it can be external beam from the outside in, or internal radiation from the inside out. Internal radiation is split up into brachytherapy and radiopharmaceuticals broadly. And brachytherapy means short distance. And so we can put radioactive sources, either temporary or permanent, inside the area of interest. It emits outwards into the area that we're trying to target. Radiopharmaceuticals are like a liquid with a radioactive payload that goes specifically to areas that have cancer. External beam radiation can be given with a few different approaches, but basically external beam radiation is from the outside in. A patient lies on a table and the radiation, and it's called teletherapy. We sometimes use that term, but again, from the outside in.
Now let's talk about these different types of radiation a little bit more in detail. So in terms of external radiation, how does that generally work?
99% of the external radiation in this country is given on a machine called a linear accelerator. And a linear accelerator can actually give you two types of radiation, something called electrons and something called photons. And photons are also called X-rays. And the listener should be aware that these terms are often used interchangeably, and they mean the same thing. So these come again from the outside in. Sometimes we can give all the dose in as little as 1 day in one setting. And sometimes it goes as long as 8 or 9 weeks. And so it really depends on that particular patient and that particular patient's type of cancer. And that's a discussion that the patient will have with their radiation oncologist.
And a common question that I get in clinic from patients is, am I radioactive after I get external radiation?
Yeah, I get that question too. That's a common question, and it's a fair question. I would probably ask that question if I was a patient, and the answer is no. Patients are not radioactive at any point during the external beam radiation therapy process, which means it's safe for them to go home and be with their family and be with their children and grandchildren and other friends and family.
Now, you mentioned one or two types of external radiation, photons and electrons. So let's talk a little bit more about these other types of non-X-ray radiation. So can you tell us a little bit more about electrons? What type of cancers or areas are we usually using electrons to treat?
Electrons are terrific. They have a very short depth of penetration. So the most common place we're going to use an electron is a skin cancer, because by design, we don't want to go deep. We just want to go a few millimeters deep to treat the skin and the area immediately below it. So that's the most common place we use an electron, and that can come right off of that linear accelerator we discussed.
And another type of radiation that I know patients will also come to and ask me about are protons.
Mm.
Can you tell us briefly what protons are?
Sure. Protons, although the physicists won't like this term, are positively charged electrons. They have a positive charge. They're hydrogen, actually. They're the H of H2O, to be precise. They have a mass that's about 1,800 times that of electrons. And what that allows them to do is go into tissue, and they do stop. They have something called the Bragg peak. Protons are available at only 1 to 2% of centers across the country. They make sense for certain cancers, and they might make less sense for other cancers. And they're on the spectrum of radiation therapy. They're a tool in the toolbox for radiation oncologists. And so what I always tell patients, discuss it with their radiation oncologist. They'll be knowledgeable in protons, whether or not they have it in their own clinic. And there are certain patients that may benefit from it. And there are other patients that probably, if there is a benefit, it's pretty marginal. And there's some patients in whom there's probably going to be no benefit whatsoever with protons over X-rays. But that's a good discussion for the patient to have with their radiation oncologist.
Now let's move on to talk about internal radiation. So can you tell us more about internal radiation such as brachytherapy?
Yeah. So brachytherapy is a specialized procedure, and it is a procedure. It may require sedation or anesthesia, or sometimes numbing medicines where the patient is awake, but we use some type of a block or numbing medicine, because it usually will involve some type of needle to be placed. But it rarely is a full-blown surgery. So that's an important distinction. It can be done on an outpatient basis. The radioactive material is placed in the body, which sounds scary, but we either place a very low dose radiation pellet that can stay in for life, or it's a high dose temporary seed. Let's talk about the first one. The low dose radiation pellet that may stay in, it will decay over time. All these radioactive materials have what's called a half-life, where in a certain amount of days, the dose is half, and then it's a quarter, and then it becomes an eighth, and then it becomes essentially immeasurable. So sometimes we place the radioactive seeds or pellets and they stay and they're perfectly fine after a certain number of days. And then sometimes it's a high dose radiation pellet that's essentially on the end of a fishing line, goes into we call it a hollow catheter, stays there just for a few seconds and is withdrawn. So again, a good discussion to have between the patient and the radiation oncologist when that's appropriate and one type of brachytherapy would be appropriate in that situation.
And then going back to that radioactivity question, you mentioned these two different types of internal brachytherapy. Are the patients radioactive?
Yes, when the patient has internal radiation placed, there is a period of time where we do caution them and give very specific guidance on the distance away that we would caution perhaps women of childbearing age or young children. And so it really varies on a case by case basis. But if the permanent radiation pellets or seeds are placed, there are very specific radiation precautions we would give to the patient. Those are instructions that are given with quite a bit of specifics to the patients and their families.
And for the patients where the radiation is placed internally temporarily, are they radioactive?
They are not. They are not radioactive the moment that radiation is taken out of them. So if they get what's called high dose rate brachytherapy, the radiation sits in what we call a dwell position for just a few seconds. Maybe we'll move to another dwell position. But as soon as that radiation comes out of the body, the patient is not radioactive at all.
And earlier you mentioned another type of internal radiation, radiopharmaceuticals. Can you tell us more about those?
Yes, so radiopharmaceuticals are really growing in popularity. It's a good way to for the listener to think about it. It's a liquid radiation. There's different ways to give it. It can be given via an IV or intravenous. It can be given via an injection, or it can be even taken as a pill. For example, thyroid cancer, we would give it as a pill. It's a radioactive iodine. For metastatic prostate cancer, there's a couple different radiopharmaceuticals out there. There's something called radium-223, and something that's growing in popularity is something called lutetium. They also have trade names, Xofigo and
Fliticvo.
And so these can be used in metastatic prostate cancer. And again, it depends on the clinical scenario when we would use them.
So tell us, how do these liquid radiations work?
Yeah, they're pretty smart. It's pretty interesting how they're designed. Maybe we'll talk about the lutetium. And so what happens is the lutetium is tagged in such a way it searches out something called prostate specific membrane antigen. So in that sense, it really hones in on prostate cancer cells, regardless of where they may be. And so it's a big differential. It'll go preferentially to the prostate cancer cells and not so much to normal healthy cells. And then when it arrives, it essentially delivers a payload of lutetium that has a very short acting distance and really causes damage to the prostate cancer, but avoids the good healthy cells.
And with these liquid radiations, are patients radioactive afterwards?
Yes, they are. And again, they are radioactive, so they may need to be isolated depending on what we're giving from others until it's excreted from the body. So there's different ways we can mitigate the risk. And again, we give a lot of education around this. And so I think this is something that radiation oncologists do very well when counseling patients who are receiving radiopharmaceuticals.
So we've heard a lot about different types of radiation treatment. How is it decided which type of treatment will be offered to a patient?
We have an expression. We want to use the right treatment for the right patient at the right time. The first question always is, does this patient need radiation? And after that, it's what type of radiation is going to benefit this patient, then for how many days do we need to do the radiation. We're fortunate in that we have a lot of different tools that can benefit patients. So I always tell the patients to go in and meet with the radiation oncologist with an open mind. And then if they would benefit from radiation, then have a discussion on what type of radiation would best serve their needs. 97, 98% of the time, nearly always, in my opinion, the right answer is in that office and in that facility. Very rarely do patients need to be referred to another center for treatment. But if that needs to happen, radiation oncologists are generally pretty friendly and have good relationships and can get the patient to the right center when appropriate.
Well, thank you, Dr. Keole, for joining us for this episode. For those of you listening, if you'd like to learn more about the topics we discussed, please visit rtanswers.org.
Thank you for listening to this episode of the On Target podcast. This episode has been brought to you by the American Society of Radiation Oncology and our care partners. For more information about topics discussed in this episode, please visit our website at rtanswers.org.